Okay, I think we can start. I'm Paul Dazan, and thank you so much for joining us today. We have a wonderful annual meeting, but we want to be in contact with you throughout the year. And this, of course, is an annual event that's extremely popular and, in my opinion, valuable. Mark Oldham will review the most critical studies from the last year in delirium. Mark, of course, is Associate Professor of Psychiatry and Surgery at the University of Rochester. He's the immediate past president of the American Delirium Society, the deputy editor of our journal, and also the head of uh, our proactive psychiatry SIG. Delighted to have him today. Please put your questions in the Q&A, and we'll try to leave some time for discussion at the end. Go ahead, Mark.
All right, thank you so much. All right, well, greetings to everyone. Thank you for joining today. As you've heard, I'm going to be presenting specifically three clinical trials over the past year from 2024 to 2025, and this is the fourth annual installment of the State-of-the-Art Delirium Research Review. I have no conflicts of interest to disclose, although one that I might add is that I am passionate about delirium, but that's not a secret. So I want to mention at the outset that the American Delirium Society is an amazing community. If you're interested in learning more about delirium, we have our 16th annual conference going to be in Denver, June the 14th through the 16th. I'm one of the chairs developing that conference. If you're interested, reach out to me. Love to answer questions and love to see a really robust presence of psychiatry as well at ADS. So the three trials I'll be presenting today all come from JAMA reported studies, and honestly, this I think really bodes well for for the delirium literature to see that it's getting so much visibility in the community and really at a high level with these JAMA publications. So we'll cover each one in turn. We'll start with the record study, thinking about persistent delirium in palliative care. The first thing I want to mention is the word agitated in this study, unfortunately, is something of a misnomer because it really includes restlessness and up. So when you see the word agitated, really what they're referring to is hyperactivity in delirium in palliative care. So for each of these, they're JAMA publications, and so they have a graphical abstract. We'll use that for starters, kind of as a landing page, and then we'll look at the methodology a little bit more in detail. So this was a study in the analytic sample of 42 men and 30 women with advanced cancer and persistent hyperactivity in delirium, median age of 64, and they conducted this across 3 acute palliative care units in Taiwan and the U.S. When people entered the blinded phase, it was a lead-in open label phase of haloperidol, but when they entered the blinded phase, they were randomized to receive haloperidol, lorazepam, a combination, or placebo. And I'll note the placebo group was not a true placebo. These individuals received an initial dose of lorazepam and PRN lorazepam. It's a placebo because they received scheduled placebo during the 24 hours of enrollment. The primary outcome was not agitation, but rather arousal level as measured by the Richmond Agitation Sedation Scale, which is the RASS. I'll be referring to it as that way. So there were a number of a priori comparisons that they evaluated, and I'll highlight them here. The first one was between haloperidol and lorazepam arms. Those who received lorazepam had a greater reduction in RASS over 24 hours than those who received haloperidol. Those who received the combination had a greater reduction than those who received monotherapy with haloperidol. People who received monotherapy haloperidol had roughly equivalent reduction in level of arousal over 24 hours as those who received placebo. But again, this is the PRN lorazepam arm. And then finally, those who received lorazepam had roughly equivalent reduction in arousal over 24 hours to those who received the combination. So lorazepam and combination, roughly equivalent. The addition of haloperidol in that combination group does not appear to have had an incremental effect in reducing the level of arousal. So, diving into the methods a little bit more. So, as I've said, this is an acute palliative care cohort. These are individuals who had a RASS of greater than or equal to 1, which effectively means restless or greater in the past 24 hours, plus either scheduled haloperidol for delirium up to 8 milligrams in the 24 hours leading up to enrollment, or 4 or more milligrams of haloperidol in rescue doses for agitation in the past 24 hours. In the interest of time, I'm not going to cover the exclusion criteria in detail, but I've listed them here. And so when people entered the open phase, they met those criteria, they began to receive scheduled haloperidol 2 milligrams IV Q6. And then when the RASS, again, was greater than or equal to 1, so that's the persistent part of persistent hyperactivity, they would receive a PRN dose, and then they could enter the blinded randomized phase. And I alluded to what +1 on the RASS meant earlier, restless, as shown here. Above that would be agitated and so on. But again, you could be eligible for inclusion if you were simply restless with a RASS of +1. Now, people were randomized to one of 4 arms shown here. This was a double dummy study. So at each time point, both for scheduled and PRN doses, they received something through syringe and also from a bag. Individuals receiving haloperidol received 2 milligrams Q4. Lorazepam received 1 milligram. The combination is 2 and 1. And for the placebo, as I mentioned earlier, that's why there's an asterisk. They received a single dose of 1 milligram of lorazepam at the outset on enrollment, and then also PRNs, they could also receive the lorazepam if receiving a PRN. Here at the bottom, I'm just saying that that they would increase or decrease subsequent doses based on high or low RASS, whether they received multiple PRNs, or if scheduled doses were held for sedation. So the primary outcome was change in RASS from blinded treatment to 24 hours. They did use a standardized non-farm protocol, which I've shown here in this table. The RASS and Memorial Delirium Assessment Scale were evaluated at baseline, 30 minutes, 1 hour, 1.5 hours, 2 hours, and every 2 hours thereafter. And they used a modified intent to treat analysis. So this is the consort flow diagram. They screened about 3,000 people, ultimately randomized 111, and then analyzed a little over 70. What I've highlighted here in this red box is that the main reason that someone randomized was not analyzed was that they died from the time that they were randomized to the time that study blinded treatment would begin. So this is a really terminally ill population in acute palliative care. So I think that also goes to how we interpret the results of this study. So in terms of patient characteristics, you see the age on average, roughly 60 to 70 as an average across the study groups. Slight male predominance in terms of the population, or so the cohort, I should say. Here in the second bar of haloperidol use, people received somewhere around 7, 8, 9 or more milligrams of haloperidol over the 24 hours leading up to the randomization. And the RASS score on enrollment at baseline was on average about 1.5. So slightly north, somewhere between restless and agitated based on the RASS score. I show this broadly just to emphasize the point, as I mentioned earlier. You see the placebo group. This tan bar represents at least, or I should say, 1 PRN dose received. And so this is why I call the placebo group really a PRN lorazepam group. This is level of arousal over the course of 24 hours. You say they all drop initially. Again, also the placebo group received an initial dose of lorazepam. I think that explains that to some extent as well. And you see as this kind of goes forward that the dark and light blue bars are lowest. Those are the 2 groups that received lorazepam, either monotherapy or combination. For context, though, our goal, 0 is appropriately alert. Our goal might be somewhere between 0 and -1 in most contexts, at least in the hospital. We're not trying to snow people. So I just want to say that the level of arousal, although we're talking about differential change in level of arousal, these are really sedated individuals. They were asleep. So in terms of strengths and weaknesses, so this is a study that focused on a discrete neuropsychiatric disturbance in delirium. And I think for that alone, this really deserves attention. Very often we just think about treating delirium, but in psychiatry, in the literature, but in psychiatry, we're really called upon to treat neuropsychiatric disturbances. So I think this represents a good model for how we ought to think about managing delirium and its discrete neuropsychiatric disturbances. They used a valid scale for arousal. They did a longitudinal evaluation over 24 hours. Limitations include, I would say, misuse of the word agitation throughout. There was no placebo group, truly. I think this is appropriate ethically, not to have a true placebo group. But again, the reference point is not ideal. Um, the fact that they used open label haloperidol initially as a run in phase, I think disfavors the haloperidol group to some extent. And also, as we noted earlier, this is an end of life delirium cohort, which somewhat constrains generalizability. What do we conclude? Lorazepam sedates patients with delirium, especially in palliative care here. And the interpretive context is RAS of -3 is seldom the goal. But it does, lorazepam definitely is a sedative. All right, the next study is suvorexant for reducing delirium incidence in older adults in the hospital. So, this is a study of roughly 200 older adults, mean age about 82, across 50 hospitals in Japan, and a roughly balanced allocation to suvorexant, 15 milligrams at bedtime, up to 7 days, or placebo. The primary outcome was delirium according to the DSM-5. Kind of high level overview of findings here, the survival curve. People who received suvorexant had a numerically lower incidence of delirium, but it was not statistically significant, even though the incidence of delirium was roughly 10% different. So 16.8% versus 26.5% over the course of roughly a week. So a few notes about suvorexant. This is a dual orexin receptor antagonist. Orexin does not wake you up, but it keeps you awake. It's said to stabilize wakefulness. As kind of a model, narcolepsy type 1 is a central orexin deficiency syndrome. Suvorexin has a half-life of 12 hours, so there may be some carryover effect into the next morning. And there are two other doors on the market, lemborexant and daridorexant, that may have different impact, if you will, regarding clinical effect. Let's see here. Design. This was a double-blind, placebo-controlled RCT that enrolled older adults with MCI, mild dementia, or prior delirium. They really wanted to focus on individuals where there were higher risk of delirium. And I'll note here, if I put in bold, they excluded people with moderate to severe dementia. I think broadly because it can be difficult to differentiate some of the baseline cognitive impairment from delirium. And I think they just wanted a cleaner sample. And so they selected this relatively narrow band of cognitive function. They stratified randomization based on admission status, so medical versus surgical, and age based on the cut points of 75 years. Participants, assessors, and investigators were blind. They evaluated delirium using the DSM-5 and the Japanese version of the DRS-R98. They used trained and certified raters, and evaluations were enriched by chart review and collateral. So primary outcome was the proportion of participants with DSM-5 delirium, and they used a modified intent to treat analysis, essentially anyone with any delirium assessments completed. So they assessed 231 for eligibility, randomized 207, and analyzed ultimately 203. Overall, the sample was relatively balanced, male and female. Most of the individuals were greater than or equal to 75 years of age, 90% or more. There was a slight preponderance of elective surgery, roughly 2 to 1, and most of the individuals were eligible because they had MCI or mild dementia. In terms of the primary outcome, again, we've said it was not statistically significant, but they did one sub-analysis, or I should say a post-hoc analysis, where they looked specifically at individuals with hyperactive plus mixed subtype delirium, and they did find that suvorexant was associated with a lower incidence of hyperactive plus mixed subtypes. And I'll note that's a post-hoc analysis. We really shouldn't read too much into it, but nevertheless, it's notable that it looks like there could have been a signal along those lines. The other two secondary outcomes or endpoints, looking at the DRS-R98, either dichotomously or as a continuous measure of peak severity, were not significant. So the strengths and limitations of the study. This is a double-blind, placebo-controlled RCT of suvorexant, and delirium was assessed by research personnel. So I think rigorous in that regard. There are a number of drawbacks, though. First off, there were roughly 200 people across 50 hospitals, which means 4 patients per hospital on average. I'm sure there were many that had more than that. However, I think this introduces concerns about inter-rater reliability. They did not evaluate sleep outcomes, which is really the putative mechanism. So we really don't know if people slept better who received the suvorexant. This was a purely Japanese cohort, so the kind of the generalizability to other populations is uncertain. They used 15 milligrams of suvorexant, but in the US, the max dose is 20. I'm not sure that has a huge impact, but it's nevertheless noteworthy. And as we've already seen, all participants had MCI, mild dementia, or prior delirium. So this was a heightened risk for delirium population. Again, whether we can extrapolate to other populations with different cognitive functional status is also unclear. So what can we conclude? Suvorexant did not lead to a statistically significant reduction in delirium in older, cognitively vulnerable, hospitalized Japanese adults. Very specific here. But I will say again, I do think there's a promising trend. I'm a little biased. I do think sleep and delirium are very closely linked. It's definitely part of the research that I'm doing now. And nevertheless, I think we need more rigorous studies looking at sleep as well as the putative mechanism. We have to demonstrate target engagement. All right. And the third study is B-free or benzodiazepine-free cardiac anesthesia for the reduction of post-op delirium, a cluster randomized crossover trial. So this was a big trial. It was a pragmatic trial, but pretty large. So they had 20 hospitals that were part of this cluster randomization, and each hospital was the cluster that was randomized each month to a policy of either restrictive or liberal benzodiazepine administration during surgery. And overall, roughly 20,000 patients were a part of this pragmatic trial. The mean age was 65. These were all individuals, again, having open heart surgery. And this was conducted in North America. I'd say most of these are in Canada. The primary outcome was delirium up to 72 hours, as assessed either by the CAM-ICU or the ICD-SC. Um, Overall, this was a negative study. You see here on the right that the rate of delirium in the two arms were 14% for the restricted benzo policy and 14.9% in the liberal benzodiazepine policy months. It was almost statistically significant at 0.07, but really this is a feature of the very large sample size, which means greater power. And so I think there's a question here about clinical significance versus statistical significance. We might entertain that distinction as well. So as I mentioned, this is a pragmatic crossover RCT where the patients and the assessors of delirium were blinded to the cluster randomization or the allocation. The study arms, there's the restricted benzo policy in which patients were not supposed to receive benzos in the operating room, whereas the liberal benzo policy, patients should have received at least 0.03 mg per kg of ideal body weight of midazolam. If I'm doing the math right, that's basically 2 milligrams of midazolam. And when you look at their E-table, 2 milligrams of midazolam is 1 milligram of lorazepam. And as a consult psychiatrist, I don't consider that liberal. Maybe in other contexts, that's considered liberal. But in any event, not a lot of benzo. Blinding. Patient and assessors were blinded. Anesthesiologists were obviously not blind. They were the ones to implement. And then the clinicians were not notified, but I'm going to presume that most of them were blinded, but potentially they found out through whatever mechanism. All right. This is how they did randomization in blocks of 2 periods. So each site or cluster or hospital was randomized to either liberal or restrictive, let's say on period 1. And because they're in blocks of 2, whatever they were in number 1, they would flip it for number 2. And then they were randomized on period 3. And then whatever it was in 3, they would do the opposite in 4 and so on. That way there would be a balanced allocation of liberal and restrictive over the course of the study. So the primary outcome, as we've seen, delirium within 72 hours detected, and this is key, during routine care. 14% rate of delirium after heart surgery, my mind seems a little low. So I'm thinking that some of the delirium probably was not picked up, and that could have affected, I think, the results. All right. So 23 hospitals were assessed for eligibility, three were excluded. The one I want to highlight is the last of those exclusion, one for inconsistent assessment of delirium. I have to imagine that of the 20 hospitals that were randomized, although they were documenting delirium assessments, I have my doubts about the accuracy of delirium detection during the course of routine care. So again, I think that's a potential fly in the ointment for how the results might be interpreted. So these are the baseline characteristics. We see the average age was about 65, about 3-to-1 male predominance, as one typically sees in cardiac surgery cohorts. Other values here, which I'm not going to cover in detail, but I did want to highlight the medications that people received in the operating room. During the restricted benzo policy, I'm sorry, I can't read, 9.1% of individuals received intraoperative benzos, so a 90% roughly fidelity to the policy. And then during the liberal benzo policy periods, 93% of individuals received benzos, so again, over a 90% fidelity. The mean midazolam dose that people received who received intraoperative benzos was about 4, which is about the equivalent of 2 milligrams of lorazepam. So again, not a lot. And then postoperatively, people in terms of benzo receipt, 10 versus 11%. And here you can see the proportions of other agents received in the operating room, roughly equivalent between study arms, if you will. So as we said already, this was a negative study. They looked at 3 other primary outcomes, ICU and hospital length of stay and in-hospital mortality, and no difference in these 2 study arms. At the bottom here, I'm also noting that one of their other outcomes of interest was recording self-reported or spontaneously reported intraoperative awareness, but nobody of the 20,000 individuals reported spontaneously that they were aware during the operation. And again, this is if you're removing benzos, you might be a concern that, oh my goodness, maybe they don't have the, they might not have the amnesia for the event. But again, this is not a lot of benzo, and no one spontaneously reported it. I do want to highlight one thing here from the a priori specified subgroup analyses. None of them were statistically significant, but notably in people who received the CAM ICU for delirium detection, it's roughly twice the rate of delirium detection as individuals, who had the ICD-SC as the tool, 18 to 20% versus about 11%. So again, I think the detection is a potential issue here. And then finally, they did a few post hoc analyses, sensitivity analyses, where they restricted the analysis to individuals who were treated according to the intraoperative policy and excluding individuals who had received benzos 24 hours, over the 24 hours before surgery. And it looks like there might be a signal. I'll just note that this very well could be confounded by indication. So I really wouldn't want to read into these data all that much. And even if you do, like still a 1% difference, absolute difference between study arms. So this was a large representative sample with a pragmatic design with greater than 90% adherence. Taking a drink here before I cough. Let's see here. Limitations. This was specific to cardiac surgery. The intraoperative benzo doses were, as I'll say, timid, and it was pragmatic, right? It was a policy, not a requirement. So a policy restricting benzos during cardiac surgery did not reduce delirium incidence, but was also not associated with an increase in spontaneously reported intraoperative awareness. So what are our take-homes from the 3 studies? Lorazepam is a sedative, even in delirium. I know people avoid it in delirium, understandably so. But sometimes there are indications in delirium, as we've noted in the APA guidelines. And if nothing else is working, it probably will be sedating, although it's not going to clear sensorium. Number 2, there was a potential signal for suvorexant, but I would just say it's not ready for prime time. And then 3rd, clonazepam 1 milligram or lorazepam 2 milligrams, or roughly that equivalent during surgery, probably doesn't cause post-op delirium. I'm going to end on the slide about ADS. I'm glad to take some questions.
Very good. Thank you, Mark. First, I'll start with an audience member asks, is acute palliative care What is that setting? Is that hospice or hospital ICU?
I mean, it's not ICU, but I mean, the way that I'm reading it, admittedly, I don't work in that setting. It just seems that this is more of a terminal population where the individuals are really kind of end of life. So I'll be honest, I'm not as familiar with that setting, but that's how I read it. It's again, as I mentioned, the main reason that people who were randomized did not ultimately receive the allocated study medication was because they died in that period. So this is a very, very sick and frail population.
Right. And I would also emphasize that is a study of lorazepam in conjunction with haloperidol because they had received a lot of haloperidol
Yep.
and given its half-life. So we learn again and again how a little bit of benzodiazepine can be very synergistic with
Mhm.
neuroleptic and a very useful effect for us. Turning to the second study, I have to summarize a little bit. Can you comment on the choice of agent, that particular dual orexin antagonist, and also other alternative might have been melatonin? What do you think they would have found with a different agent?
Yeah, so I don't know about melatonin. I mean the APA clinical practice guidelines, we actually give a suggestion not to use melatonin either or Meltion to prevent or treat delirium. The studies are just not excellent. We've never demonstrated target engagement either on circadian measures. So I think that's really a huge limitation in the literature. I mean, the 12-hour half-life is also a concern. I think daridorexant with a half-life of 8 hours might be better positioned in terms of pharmacokinetics to target just at night. Lemborexant, by the way, has a half-life of like 15 hours or more. So I think that might not be ideal. I'm personally studying daridorexant. Um, I'm not, no financial conflicts here, but I'm studying it because I think that it actually is a more promising agent. I think we, though, have to demonstrate target engagement, that we are improving either circadian or sleep measures when we use these kinds of interventions. This really speaks to mechanism.
So, notwithstanding my concern about the recruitment system, and they 50 hospitals for 2 years, and they get 200 patients. So,
Yeah.
nevertheless, I think this is a very suggestive study.
Mhm.
Let me turn to the last study. Uh, that incidence of delirium around 14%. That
Mhm.
seems rather low.
It does. It does. So, I mean, my research has been with cardiac surgeons and anesthesiologists since I arrived in Rochester, like the last 7 years. My studies have found anywhere from a 20 to 30% delirium rate after cardiac surgery. And so the 14 or 14.9%, I just don't believe it. I would expect, even after cabbage, we have found about a 20% rate of delirium. And I would expect that there is more delirium that wasn't detected. And I think any good study of delirium, really, they need to have, I mean, I'm going to say research grade delirium assessments, systematic evaluations for delirium, deliberately doing cognitive assessments to demonstrate who has delirium. Because during routine care, we just know that it's being missed. So I agree. That's a bit of a concern in my mind as well.
Well, I'm glad the study came out in the direction that it came out, but I do reserve the right to worry. If you use imprecise methods and you use a low dose of your intervention, you're going to have a negative study. All
I
right.
think so.
Well, we've got to stop. Thank you so much for joining us. Don't forget our next monthly webinar, February 11th, a case conference about traumatic brain injury. Thanks so much. Bye bye.
Take care. Thanks.